Good afternoon to all of you. Dr. Jothydev Kesavadev doesn't need introduction to this August Hall, very renowned diabetologist. His work in insulin pumps, continuous glucose monitoring, and telemedicine is internationally recognized. And he has introduced DTMS in India, that is Diabetes Telemanagement System. He is father of digital technology in diabetes in India. The floor is yours, Dr. Jothydev.
Thank you. Thank you, Dr. Anita Nambiar, Madam, and Dr. Soni, respected chairpersons. So I am very grateful to the organizers, Dr. O.P. Sharma, sir, Dr. Sajesh, Dr. Anita Nambiar, Dr. Hari, sir, and all the other friends and mentors for inviting me. Geriatrics has always been a passion for me. And Dr. Sajesh has asked me to discuss on continuous glucose monitoring and other life-saving technologies. And I don't have anything to disclose pertaining to this lecture. And this is Dr. N.N. Ashokan Memorial Lecture. Dr. N.N. Ashokan sir used to be a very, very close friend of mine. And I know how he has been associated with Dr. O.P. Sharma and the Geriatric Society of India for many, many decades. We used to travel together. We used to have long telephone conversations. A lovely gentleman, so passionate with his profession and also retaining and maintaining the associations and friendships. And this is one picture, an old one. And this is a geriatric conference. And this was a geriatric conference at Amrita Institute when both of us were invited as a faculty in 2001, more than 23 years ago. And this is when Dr. N.N. Ashokan sir invited me to his IMA at Moatuvida. And that was in 2009. Very old pictures. I do have many other pictures with me. But this is not the occasion for going back to the memories I know. And I have a very, very long association with O.P. Sharma sir. Maybe close to 3 decades, right sir? And it was in the year 1998 or 1999 when I became a life member of Geriatric Society of India. And in 2013, he presented me with an award. And for a few years, I was the vice president of Geriatric Society of India. And I always respect him for his passion and dedication for geriatrics in the country. And I still recall attending the training programs at Delhi with Dr. O.P. Sharma sir when I was an assistant professor at Trivandrum Medical College, the Government Medical College Trivandrum. And I am so happy that our dear Sajesh has taken over the responsibility. Of course, O.P. Sharma sir always used to discuss with me, but I somehow shifted my duties and responsibilities in diabetes. But I have been telling one of the friends whom I met today morning, who started the geriatric department in Trivandrum at KIMS, that in Government Medical College Trivandrum, we started geriatrics department long ago. And that was in late 1990s. And somehow I realized that it is more creative and productive working in the private sector than in the government sector for many reasons. Of course, everyone will have their own justifications, and thank you very much again for inviting me, because N.N. Ashokan sir, O.P. Sharma sir, Geriatric Society of India, they're all close to my heart, very close to my heart. So let me discuss something which is preventive in diabetes, preventive in elderly, preventive in geriatrics. I am also close to 60 years, and so I would rather prefer discussing something as ours rather than yours or somebody else, because geriatrics is all going to be part of us only. So why should we keep on telling that you or he or, because when I visited a health secretary long ago when we started geriatrics department, he said that why are you bothered about geriatrics department in the medical college? It is something which is going to affect the elderly population. He was at that time around 55 years old. And now he is having a miserable life. Anyway, we should all be prepared for geriatrics. And that is the reality. And this is a story of an 81-year-old lady with diabetes of almost 1 decade. And she has symptoms which are attributable to hypoglycemia. J.K. Sharma sir, thank you very much. Have a nice journey back home. He didn't, yeah. And this lady, despite an A1C of more than 8%, Sharma sir, happy journey. Thank you. And despite a very high A1C, this lady is having probably symptoms of hypoglycemia, especially minor episodes of recurrent hypoglycemia, which is so commonly observed in above the age of 60 years, which is unrecognized with the usual glucose monitoring with the glucose meter or the glucose monitoring in the laboratory. And we did a continuous glucose monitoring with the prevailing medications, and that was a human premix insulin and metformin given twice daily. And this was the time in range. I believe that many of you are aware of time in range, but at least if 5% of you are unaware, I will repeat the same because it will be useful for all of us practicing diabetes, since it is so commonly observed in our population. This green zone is a time which should be spent in normal. But in above the age of 60 years, we all know that hypoglycemia is probably much more hazardous. It is life-threatening. And for this lady, more than 80 years old, 7% time was below 70 and 7% time was below 54, which is significant. 14% of time is spent below the range. So we decided to shift her to a co-formulation, and she could afford a GLP-1. And this is how after 3 months to 6 months, it has improved. The time in range has gone up to 89%. And more important than time in range, I would say that much more important than time in range in elder population will be elimination of hypoglycemia. So if I go back to the original, you can see that the 36.2% glucose variability has been reduced to 22.3%. So there is a significant reduction in the glucose variability as well. And this is what Dr. Anitha Nambiar Madam mentioned in the beginning. We started telemedicine in diabetes way back in 1997. And these are some of the screenshots of some of these patients being followed up for many decades. Consistently normal, I would say, acceptable hemoglobin A1C. Creatinine in 2015 used to be 1.6, but still the EGFR is maintained at an age of more than 80%. And this is the beauty of titration and observations and counseling regularly over a structured telemedicine program. And this, I think, we could have discussed over the last 3 days what happens in the process of aging. And if you are brave enough to have a clamp study, you can demonstrate the reduction in insulin sensitivity when we start aging. And if you are able to demonstrate via a continuous glucose monitoring device, and this is how at 1 hour or after 1.5 hours of food, the glucose can be above even 180 or 190, and the hemoglobin A1C can be still below 5.7%. So you'll be missing those areas in between, and this is more like a video when compared to a picture which is taken from a glucose meter. So hypoglycemia in the elderly population will have a deleterious impact, will have an impact on cognitive decline. So this is one of the important reasons for cognitive decline in the elderly, in addition to what we are already familiar with, and that is the cardiovascular risk involved, the MI, the cardiac arrhythmias, even the stroke, which can happen even during the sleep. Hypoglycemia is more so important when somebody is sleeping at night. And this is from a very recent publication. Patients with hypo episodes had a 44% increased risk of dementia, one of the very, very common reasons. So I said in the beginning, though this is technology related, this is more for prevention. And this is compared to those without the episodes of hypoglycemia. And the risk of dementia significantly increased with both single and multiple episodes of hypoglycemia. And if I am to dissect, and if I am discussing the hazard ratio, The risk of dementia increased with the number. With one episode of a hypo, the HR is 1.26, and with 2 episodes, the hazard ratio is 1.8, and with 3 or more episodes, it is 1.94. So, more the episodes of hypoglycemia, more the risk of dementia in the elderly. And I still remember a publication in 2003 from the American Geriatric Association on recurrent episodes of unrecognized hypoglycemia. And severe hypoglycemia is associated with more than 2 times higher risk of falls. And falls is a geriatric syndrome with atypical presentation. You might miss a fracture, and there is a high absolute risk of fall with every episode of a severe hypoglycemia. And the overall chance of falling in the elderly, 59% higher. And for those on insulin, because many are on insulin, because insulin is the drug to be used for diabetes in the elderly. If it can be properly or smartly administered, there is a 162% higher risk of falling, 162% higher. But still you have to use it. And that is where technology will have a space. Technology will have a space in preventing hypo, in preventing falls, in preventing dementia. And the question usually very often asked is, why should you go for continuous glucose monitoring? It's a very, very expensive device. And why should you go for that? You can go for regular monitoring. The reasons are multiple. More than 25 reasons are there why the continuous glucose monitoring is gradually replacing the currently prevailing metrics. And one reason is, look at the 3 beautiful ladies over there. They're very happy. And something common is the hemoglobin A1C. And the hemoglobin A1C is the same, 7% for all the 3 ladies. However, if I am to analyze the continuous glucose monitoring data, it is different. The lady number A is having a significant glucose variability, whereas the lady number 2 is having 70% time in range. Look at the green zone over there. And the third person, despite an A1C of 7, is having 100% range. 100% she is within the range of an optimal glucose control. So that makes a difference. And that clearly explains why some people are developing complications. Some others are not developing complications of diabetes. And this also clearly explains the reasons for mood swings in diabetes, the difference in the energy levels in the presence of controlled or even uncontrolled diabetes. And the reason is very simple, it is glucose variability. And long ago, our good friend Sheriello from Europe, so we worked together in many research projects, and he has demonstrated long ago that oscillating glucose levels, oscillating once in every 6 hours, and this is an experiment. He showed that when compared to consistently high levels of glucose, oscillations results in more of endothelial damage and more of vascular complications in diabetes. And this is something which is well established over the years, and CGM is the only way by which you can measure the glucose variability. Once in every 5 minutes or once in every 15 minutes, you have a glucose. And this is something already familiar to all of you, but I think, again, it's worth a recap. In those with no propensity to develop hypoglycemia, fairly normal, fairly healthy people, you can aim for a time in range more than 70%. So when I say 70%, that corresponds to 17 hours in 24 hours. Very simple. And when I say time in range, the lower limit is 70 and the upper limit should be 180 milligrams per deciliter, between 70 and 180. That is the acceptable range in diabetes control. And level 1 hypo is below 70, less than 4%. And level 2, it is a more severe form of hypo, that is less than 54, should be less than 1% of the time. 1% means 50 minutes. So less than 1% means preferably 0% of the time. But this area is more important for the discussion today, and that is in the elderly population. Elderly population is not defined by age. So I repeat, elderly population in this consensus is not defined by age. It can even be a person at the age of 40 years, but that person is a person having multiple comorbidities and with the propensity to develop hypoglycemia induced serious complications and consequences. And in that case, you need to aim only for a time in range more than 50%. So only 12 hours a day that person need to be within range. And this is to avoid hypo. And the permissible level is less than 1%. There is no level 2, it is only level 1, less than 70%. Of course, this is pregnancy where you have a different low and an upper limit. And there are a lot of studies in the population, and that is older and high risk, and that is under the same category. Same category. And this is a South Asian recommendations and a consensus from multiple countries where we were all part of this consensus group, where there is a buffer. At the lower range is replaced by 90, 70 is replaced by 90, and the upper limit 180. And this is again to prevent hypoglycemia. But I will probably state something which is of importance in clinical practice. Though the recommendation is only 50%, you have to consider the remaining years of life expectancy. So if the remaining years of life expectancy is more than 10 years, and if the person is devoid of multiple other complications, and if you have a structured protocol for glucose monitoring, aim for more than 55% gradually. Aim for more than 60% or even more than 70% is acceptable, provided you can prevent level 1 hypoglycemia. And this is with respect to how frequently you have to repeat the time in range. Of course, if somebody can wear a sensor all the time, affordable, well and good. But if they cannot afford, the minimum which is recommended for a person who is under good control of diabetes is once in every 6 months. And this is again from the South Asian recommendations. And for somebody who is exceeding the time below range with more hypoglycemia above 4% or more than 5%, repeat it more frequently, once in 3 months, once in 2 months. But everything ultimately depends on the clinical judgment, your common sense, and the affordability of the person. If they cannot afford, go by the ordinary glucose monitoring. And this is a classical AGP report to be handed over to the person. It has got 3 components. One is the TIR metrics. The middle component is the AGP graph, that is the ambulatory glucose profile, which looks like a 24 hours model graph, but this is collated data from multiple days. Minimum should be more than 14 days, and the bottom panel is used for coaching the patient, and that is the daily glucose profile. So useful. And if somebody is questioning you, it can be a friend in another fraternity, it can be a cardiologist or a neurologist or a nephrologist. If somebody is questioning you, these are the answers. For every 10% difference in the time in range, there is a 64% increase in retinopathy, 40% increase in microalbuminuria, and there is robust data to support all-cause reduction in the mortality, all-cause mortality, CV mortality is similar to the drug trials with gliflozins and GLP-1. And this is level 1 evidence. And because of the level A evidence, almost all the scientific bodies like the American Diabetes Association, the American Association of Clinical Endocrinology, the American Geriatric Society, all of these organizations are endorsing, including our own RSSDI. And the reason is very simple. Reduction in the huge burden of hypo, reduced frequency of hospitalizations due to emergencies of either diabetic ketoacidosis or for hyperglycemia, and patient-reported outcomes, robust improvements in quality of life and satisfaction. Now moving on to the different CGM devices available, because you have multiple choices available in the market, choose a device which has got a MARD, that is mean absolute relative difference, below 10%. It should be a single-digit number, which is highly accurate, reliable, even in the hypoglycemic range. And this is how the devices have evolved. And in 2024, this year, we are celebrating 20 years, 2 decades of continuous glucose monitoring in India. And this is the first CGM device, a huge cumbersome device, still with me. And this was launched in the year 2024. But the revolution happened in 2015 when user-friendly smaller devices were launched. And now it is completely digitalized, and you can have this in your phone. And this is Libre Link app, and you can share. And that is something which is so important when we are caring our elderly population. We can share the data with 20 other people, with the children or with relatives or with a nurse or a doctor or a caregiver. And we can also, in turn, a nurse in the hospital can also remotely monitor 20 other people, apart from telemedicine. And the entire data is available in the cloud platform. And these are some of the challenges when we are using in our elderly population, when there is a cognitive dysfunction, memory when it is impaired, forgetting to scan, and there may be gaps in the graph and difficult to analyze the pattern. And another domain is difficulties in learning, mental dexterity. And when there is a difficulty in executing the function, despite a CDM, the hypos can still remain, and that can also happen. So you should be selecting the right candidate for these technologies. And these are the benefits and challenges. It invariably will have multiple benefits. A plethora of benefits are offered by all these technologies, but requires that the patient should be changing the sensor once in every 14 days. And hearing and visual impairment will also have a huge impact, and frequent alarms, alarm fatigue, and so on. And it's similar to the hemoglobin A1C categories. There are also categories for TIR for somebody who is having poor health. And when somebody is having an end-stage disease such as a malignancy under palliative care, then you need to probably have a target of between 100 and 250 milligrams per deciliter. So that is allowed, and this is similar to the goals for hemoglobin A1C. There are 3 goals in the elderly population. Moving on to, because I will be discussing on some wearable sensors as well, which will be very useful in our population. And this is automated insulin delivery. And this is available in our country since 2022. These are not the conventional insulin pumps. These are devices which automatically reduces the dose of insulin when there is a hypo, automatically increases the delivery when there are chances of a hyperglycemia, automatically stops insulin when there is a prediction of a critically low glucose, and automatically resumes when it is back to normal. So these are the devices, when compared to the earlier devices, have significant improvement in the time in range, more than 90 or even 95%. The users rated, and this is the perceived benefit. AEDs are perceived as highly beneficial when compared to the sensor augmented conventional insulin pumps. Relatively very, very expensive, but used by children as well as thousands of elderly in the country. Moving on to the user-friendly devices, inexpensive devices. Rather than simply advising a glucose meter, there are 3 or 4 branded glucose meters where you have the capability of connecting via Bluetooth with mobile phone. And here again, the advantage is whenever someone is checking the glucose levels, you can remotely monitor with seamless possibilities, can log in any data. And similar to a companion is required for diabetes care. There is a companion, and this is a green monster which keeps on smiling, talking to you. And let me tell you something, this is available free of cost. From Akuchek family, My Sugar is available totally free of cost. And this is the #1 diabetes mobile health application globally used by 4 million people. And it was actually invented by a patient. And Akuchek has acquired the My Sugar mHealth app, and will be soon available along with the new upcoming CGM with predictive capabilities. And this is OT Reveal platform, and in the cloud platform, we can remotely monitor even from our hospital. Whenever they are checking the glucose, we'll get the historical pattern and so on. And remote blood pressure monitoring, it is it is endorsed by all the scientific organizations, the American Heart Association, the American Geriatric Association, the American Diabetes Association, and in the guidelines from the RSSD, where I am also part of the guideline committee, we have also endorsed the use of home blood pressure monitoring. And there are BP patterns which are fairly very accurate, recommended by the scientific. And this is one example of an Omron Connect, which connects to a mHealth application for both blood pressure and for body weight and many other parameters. And moving on to smartwatches, another innovation been there for more than 10 years now. More than a dozen players are there in the market, but I'll be discussing only on Apple Watch because I'm a fan of Apple Watch from the beginning and from the launch of Apple Watch onwards. We can diagnose a MI. Of course, it is not certified for diagnosing a heart attack, but during the COVID pandemic, I had the experience of diagnosing MI in 2 patients, and this is at baseline. The ECG looks normal, and this is after climbing the stairs. And this is repeat the ECG, and he has sent it me across the IMS via the Apple phone, and this is the PDF format. And the ECG is available within 1 to 2 minutes, less than a minute probably. And this is significant STT changes, and I could refer him to a nearby hospital for an intervention. And atrial fibrillation, so important, and it has been there for many years now. It automatically detects and gives an alert when there is atrial fibrillation, or when there is a low heart rate, or when there is an irregular rhythm or a high heart rate. All of these available for more than 8 years. Very, very cost effective, very, very cost effective, and it can automatically dial an emergency number. You can have 3 or 4 or 5 emergency numbers, and either manually or automatically, when there is a fall or when there is an accident, it automatically will alert your caretaker. And the caretaker or the relative can be in another continent as well. And if you are worried about the cost, even the older models have fall detection. So even the older models, they are very cheap in Amazon. From series 4 onwards, fall detection is available. Sleep apnea from series 8. So many, more than 100 parameters available. So we don't have the time to discuss all of them, but I will discuss something which is a good news, which is so important in the elderly population, that is impaired hearing. The AirPods Pro is FDA approved for hearing test. And many of us are using the AirPods. And this is also, for once you do the hearing test, this is from my own phone, you can have the hearing test, and then you can, at the end of the hearing test, the AirPods Pro will automatically adjust the audio settings to amplify the sounds, to specifically tailor, and this is custom made for our hearing profile. And you can continue using this as a hearing aid. So the technology is so advanced, and most of these advances are for people who are aging like us. And this is a sleep tracker, the stages of sleep, the duration of sleep, and this is another 1 hour lecture from me. So if you are interested, you can go through my YouTube channel where I have posted these related to the Apple Watch. Though many other wearable devices are there, this is so useful. And this will also provide you with the medication reminders. If I have forgotten my flu shot, it will remind me. If I have forgotten my statin, it will remind me. It will appear over the phone, it will appear over a watch. So useful. And in a noisy environment, if it is 80 decibels or more, it will remind you, it will provide you an alert. And for meditation, for mindfulness, for breathing exercises, and many more. And these are some of the medical alert systems. I am not going into the details of this. This is Care Predict. Again, artificial intelligence. Apple Watch has got multiple ML algorithms as well. And this has AI-based tracing and hygiene habit. It will also monitor number of times the elderly has gone to the toilet, number of times the senior has eaten food, and so on. And GetSafe is a medical alert system which can be worn around the neck as an ornament, like a necklace. And this is again a fall detection and an alarm sensing device, and it can be placed in multiple places in the house. Especially useful for somebody who is living alone at home. And I am going to stop here, and with the permission of the organizers, let me invite all of you. Many of you are part of a JPF program. And next year we are having the 13th anniversary of JPF, 11th, 12th and 13th of July. And the biggest program is also coming to Kerala. But before that, in Jaipur, we have the technology update, that is the World Congress of Diabetes Technology, and in 2025 we are organizing it in the month of May between 9th and 11th. Again, back to one of the old pictures, very old picture, and this is 2002. And in the middle, you have the then Health Minister, Shankaran, some of you might remember. And this was the RSSDI 2002. And our dear Ashokan sir is over there as an organizer. And this is Dr. Siddhartha Das, the then president of the RSSDI. A very nostalgic picture, isn't it? And with blessings of Dr. N.N. Ashokan sir, Anita madam as the organizing secretary, and me as the organizing chairperson, next year, we are organizing, after 13 years, RSSDI is back to Kerala at Kochi from 6th to 9th of November 2025. And once again, I thank the organizers, O.P. Sharma sir, Sajesh, and all my friends for giving me this opportunity. Thank you very much, dear friends.
Thank you very much, Dr. Jothydev. Myself, Dr. Sonny Joseph, and Dr. Anita, it's our privilege to be here with you as a speaker and chairing this Dr. N.N. Ashokan's lecture. The topic which we discussed was very, very informative, and I think all of you agree to that. A big round of applause to Dr. Jothydev. We'll take a few questions if you have any. His YouTube and all these things will be answering most of our queries. I think out to anything.
Dr. Jothydev, it was a wonderful talk as usual. So the current ADA guideline says that one should use CGMS in elderly if required. It has been emphasized again and again. And secondly, we see HbA1c though is important, but in elderly people you may not go according to that. But the point of time, the sugar may be 50 or 60. And if you think that the HbA1c was high, so this is not important, it's not so. So for elderly patients, it is important that we should, HbA1c is important. It's not that it's not important, but at that point of time, what was the sugar, that should also be taken into consideration. It's not it. So in elderly patient, it is not the HbA1c that is too important, but that point of time sugar, sugar is very important.
Well, wonderful lecture, very practical one. I precisely remember about nearly 15, 16 years ago, CGM was something new and people thought it's a fancy one. And we met in one of the conferences and you sat patiently with me and you said, sir, the biggest thing is the disparity that we get, as Dr. Anita mentioned, that HbA1c is more, fasting sugar is less, or it is normal. Then, or if the fasting sugar is normal and HbA1c is high, the patient will ask a question, what are you going to do? My sugar is normal, why are you increasing the drug? So that time you explained that the events in the brain, whether it is some kind of strokes or things like that due to arrhythmias like atrial fibrillation or ventricular ectopics due to hypoglycemia, or falls due to hypoglycemia in the middle of the night when they go to pass urine, or the fractures due to hypoglycemia, they will all be preventable once we have CGM, because we will know exactly when to give the drug and what to give the drug. I think that times you're saying, I took it with a pinch of salt, but lately in the practice, then I saw the same thing and I salute you for that.
Thank you very much, sir. I think one more question. Yeah.
Jothydev, you mentioned about the sensitivity of various CGM measures available in the market. All are, I think, it's measuring the interstitial fluid glucose. So what make the difference in the sensitivity among different CGM machines, CGM monitors?
Yeah, that's an excellent question. So you remember that CGM has been around for 20 years in India. And it was originally launched in the year 1998. And every 2 or 3 years, there has been upgrade in both hardware and software. The original CGMs all required a calibration by entering a glucose value from the glucometer. And nowadays, it is self-calibrated devices. Some of them still require a calibration in between, So when you are measuring the interstitial fluid, it is not the blood glucose. So there will be a lag, and the lag is usually 5 to 7 minutes. And if the glucose is going up and down very fast, like in brittle diabetes or in type 1 diabetes or in somebody having diabetes for more than 20 or 25 years, then the lag time between the interstitial and the blood glucose levels could be more than 22 minutes. So with the help of artificial intelligence and algorithms, actually this lag time has been rectified. And so in the CGMs which are available now, if you simultaneously measure a glucose level in the glucose meter, it will be almost the same. Or it will be plus or minus 10 or 20 or even 30 milligrams. Why I am telling this? Even when you are comparing between the glucose meters, if there are 10 glucose meters, the 10 glucose meters will provide you with 10 different values. And you have a Clark error grid zone. You know the Clark error grid zone where you compare the glucose meters and you look for the accuracy. And there, when you are comparing with a yellow spring instrument, that is the standard, it should fall. At least 99% of the value should be falling within the zone A. So there are 3 or 4 glucose meters which are fairly very accurate. Likewise, there are 1 or 2 sensors which are fairly very accurate. I don't know whether we have any stalls here. And this accuracy, every 1 or 2 years it is improving. And those which are very, very accurate are approved for non-adjunctive use. Non-adjunctive use is you can make a dosing decision for a insulin, or you can treat a hypoglycemia without checking with the glucose meter. So there are 2 or 3 sensors which are approved by US FDA for non-adjunctive use as well. Why I am telling this is there are so many sensors around now because it's a growing market, but all the sensors need not have the same accuracy, and there can be lot to lot differences as well. That answers your question.
Yes, it's clear.
Yeah.
Are these CGM monitors are expanding outside diabetes? Something like
Very important question, because very pertinent question. I am on a CGM all the time and I don't have diabetes, and I am so happy that CGM is now approved for improving the metabolic health. In the United States, there are 3 CGMs which are available over the counter, and one from Freestyle Libre, the same popular sensor in India. Another sensor is available by the name Linko, and this Linko is for people without diabetes, for improving their metabolic health, because studies have shown that when you're using a CGM, you retain the normal body weight, and for those who are overweight, CGM also helps in reducing the weight, provided they are trained and empowered.
Is there any difference between these 2 CGMs? Like you told for non-medical use, non-diabetes use.
I will tell you. There are subtle differences in the way you are using it, with the lower limit, the upper limit, and so on. I think the time is over, and I can provide you with more information. The over-the-counter CGMs are not prescribed, so the cloud information won't be there. The other one can be accessed remotely by the doctor and the hospital.
Thank you. I think we'll close the sessions for the function.